Good morning.
Good morning, everybody.
Good morning, doctor.
Good
Morning, doctor.
morning. So we'll start in 1 minute.
Okay.
Okay, so hello, everybody. This is the protocol that we will be using when we resuscitate newborn babies, whether in the resus room or in the NICU. And the first session, we've talked about the purpose, about the anticipation, training, and the definition of high-risk delivery, including maternal and fetal conditions, and also complication of antepartum and delivery. And we have a list of them, and you have the list also. And we've talked about the challenges that the preterm babies are exposed to, such as hypothermia and the reason, inadequate ventilation, infection, and also organ damages. We've talked about that. And we've talked about the an overview about the resuscitation, how we stabilize. We've talked also about the antenatal consult and the need for that to inform the parent, and also give them a written handout, which this will increase their cooperation, decrease their complaints. An overview of resuscitation, how we, the first questions, the first 3 questions, when 10 years ago, it was like 5 questions. Now the 3 questions is the infant is the infant full term? Does the infant have good muscle tone? Is the infant, and by then we decide, does the infant need resuscitation or not? If the infant does not need resuscitation, then he or she goes to the routine care or well baby care with mother. Mute yourself, yeah, and then after if we decide no, there is the question, if these 3 questions, the answer is no, then NRP should be initiated, and we start with the first 30 seconds of positioning, warming, clearing airway, tactile stimulation, and so on. And then by the second 30 seconds, the question, if the baby improves, then he goes to something called monitoring care or intermediate care, where we don't do anything other than feed the baby and observe the baby and check the vital sign every few hours. If the baby is not improving, the second third is 2 questions. Is the baby crying or breathing? And the second is the heart rate above 100 or below 100. If the heart rate is below 100, then you need to start PPV. If the PPV is not effective, then you need to look to Mr. Soba, okay, which is applying the mask, suctioning, repositioning of the baby, increasing the pressure of the positive pressure ventilation, such as closing the pop-up valve, and also may provide alternative airways such as intubation or laryngeal mask airway. If after 1 minute the heart rate, now we need to decide, is it above 100, then we stop PPV. If it's between 60 and 100, then we continue PPV. If it's less than 60, we need to provide chest compression. And when we decide to provide chest compression, we have to have effective ventilation, which means at that point we might think of intubate the baby. When we provide positive pressure ventilation, it should be somewhere between 40 to 60 events per minute, and that depends whether there is chest compression or not. We need to monitor the saturation, and the best by applying the pulse oximetry, and we need to monitor the heart rate, and the best by applying the ECG. Now the oxygen saturation might give you the heart rate, but not very accurate. Auscultation, you might hear the heart rate, but again, it's not inaccurate. So the best to count the heart rate and look and monitor the heart rate is by applying the electrocardiogram. The further resuscitation is depending on the response. And remember, we've said the Mr. SOBA, which is mask, repositioning, sectioning, opening if there is no effective ventilation. Alternative airways other than mask, we've talked about intubation and laryngeal mask airway. And then we will be guided by the heart rate. So remember, at the beginning of resuscitation, we asked 3 questions. After 30 seconds, we asked 2 questions. And after the 1 minute, we ask only 1 question, the heart rate. So first we say, is the baby calm? Is the LICA is clear? And is the baby breathing and crying? That's the decision to resuscitate. The second, after 30 seconds, now we look at breathing and crying and heart rate. After 1 minute, we only look at the heart rate, above 100, between 60 and 100, and below 100. And that's how we decide to continue ventilation or not. Now, we've reached to this area where if the heart rate below 60, we need to do effective ventilation. And if there is no effective, look at Mr. SOBA. If you cannot achieve, think of alternative airways. After effective ventilation and the heart rate is below 60 at 1 minute, you need to provide chest compression. If you decide to provide chest compression, the airway should be secured. If you provide chest compression after like 90 seconds and there is no effect, it's still the heart rate below 60, now you need to start to think of medications such as epinephrine, whether it's an IV or through ATT. Now, you need IV. The best way is to have a vascular access, which is the UVC. And when we do UVC in the delivery room or the resuscitation spot, we do low lying. So because it's a very quick one, just to give medication. But if we want to do the UVC in the ICU, no, it should be higher and should be the standard aseptic technique. If the heart rate become more than 60, then you need to stop chest compression and continue PPV. If the heart more than 100 and the baby is fine, then you need to stop and maybe you give oxygen by blow-by. And remember, oxygen by blow-by only for, or incubator oxygen only for resuscitation, only for a short time. No baby deserves to get non-blended oxygen for a long time because oxygen are toxic. They have free radicals and can cause chronic Lyme disease, and it can pre-program the body, and it can affect future immunity, and it can affect the eye. So nobody should receive incubator oxygen. Nobody should receive oxygen by flow without blending. So that means you should have a medical air, you should have oxygen, and there should be a blender to decide how much flow and how much oxygen. You cannot only depend on the oxygen flow to give oxygen. You can do that temporarily for resuscitation if you don't have. So again, if it's below 60, you did chest compression, you need to give medication. If it's below between 60 and 100, stop medication, stop chest compression, and continue PPV. If it's above 100, then there is 2 things here. Either above 100 and there is labored or cyanosis, then you might think of providing respiratory support. It can be CPAP, it can be nasal flow. And you need to monitor oxygen. When the heart rate above 100, but there is no labor breathing, then you need to give for a short time oxygen blow-by until you withdraw it slowly from the baby. Now, some of the babies who are premature, especially those below 30 weeks, you might need to do elective CPAP. And remember, CPAP should be variable flow CPAP that have a fluidic flip principle, which means the baby will not breathe against the pressure when he or she are breathing out. That can be used only for transport from a ventilator-driven continuous CPAP, or using ram cannula, for example. because it's easy to fix and quick to fix. But this should not be for through time, because if you're still breathing, again, exhalation, again is the pressure, you'll be exhausted with time and you'll need intubation. So it's vital to have a variable flow CPAP at the nose when we have more premature babies. And the target to start CPAP is at 2 minutes. So remember that. Now, when the baby receives first step of resuscitation and need monitoring, should be admitted to an ICU, but as a nursery care or intermediate care, depending the baby is insured or not insured. In a baby less than 35 weeks, that these babies are more than 35 weeks and they needed just first step of resuscitation. So they have to go on. Remember, if you provide PPV, it's an intensive care, but we might consider it intermediate care just for financial reason. But if the baby need PPV, then it's an intensive care. You need at least 24 hours monitoring. If the baby more than 35 and only one step of resuscitation, that means 30 seconds, and he's responding in 1 minute, then this baby might go to intermediate care or monitoring care, where we observe, we check the sugar, we establish the feed, and check the vital sign every 4 hours. If the baby less than 35, this is an ICU admission, because the baby can go home, cannot go home, and he is less than 35. Any premature baby less than 35 need an ICU admission. Now, it's vital to remember we don't have only the breathing, we have to control the temperature. So, because controlling the temperature prevent or minimize heat loss. So when you prevent heat loss, we will prevent dehydration. We'll control oxygen, because if a baby need to work to control his or her temperature, that means need more oxygen, more energy. So first we have to put a baby in a warm towel or a blanket. The most important point, especially for those less than 30 weeks, is to raise the room temperature of the labor room or the operation room up to 26 degrees Celsius. And remember, this is very hot. So need to be adjusted at least 30 minutes if possible before delivery. So we have to call the maintenance to control the temperature if we cannot control it ourselves. We can also use an incubator and put the baby inside the incubator. The room temperature control is very important because we have to do delay cord clamping. And the baby at that point will be naked. So he might get like hypothermia. And remember, hypothermia is a more serious than even asphyxia. So it's very important that this baby should. And the first thing you do when the baby arrives to an ICU is to check the temperature, check the sugar. Temperature and sugar and saturation. These are 3 points that you need to remember always when the baby arrives to an ICU. So other method of warming, there are many. Swaddling the baby after drying, skin-to-skin contact with the mother while doing, for example, delay cord clamping. Use the polyurethane bags or the plastic bag and wrap the baby, especially those below 1500 grams. We can use warming pads. We can use the heater, the radiant heater of the resuscitation to control the temperature. Or we can use the servo control, which means that you put a probe on the skin of the baby or in the rectum and connect it to the incubator or the resuscitators to control automatically the temperature around the baby and the baby temperature. Remember, when we measure the temperature manually, it should be rectal temperature. Using the infrared camera by using tympanic or tactile from the skin is inaccurate. Okay, we cannot use it in an ICU, and especially in pediatric population. You can use it as a mass screening, for example, for in the market or in the airport or in entering this hospital as a screening. That should be okay. But for intensive care and no, this is incorrect. We need to use rectal temperature or at least axillary temperature. And when we mention the temperature like the degrees Celsius, we have to say the number without adding or subtracting anything, but we have to say, for example, 36.5 axillary, 36.6 rectal. You don't need to add or remove anything from temperature when you report the temperature. For a baby who need respiratory support and need humidification, you need the temperature of the incubator to be 36 to 36, 37.5, or the temperature of the baby. And you can have, if you decide that you need less than 36 for any reason or moderate hypothermia, then you need to seriously monitor the baby. So again, controlling the room temperature before starting delivery is vital to do a delay cardiac clamping. And remember, if you didn't have time and during the day, you can put the baby on the mother chest, and that will be a problem during C-section because you cannot do that. So it's vital, it's very important in C-section that you turn up the temperature in a good period of time prior they start up to 26. And this is a very survival indicator, a very important survival indicator, to turn up the temperature up. And the first thing you check when the baby arrives to an ICU is the temperature, also sugar and saturation. So if you control the temperature, you need now to be prepared for the airways. Any infant requiring further interventions after the 30 seconds, you did the stimulation, you did the positioning, but the baby still need some intervention. Then you need to mute yourself. Once the baby need further intervention after 30 seconds, you need to make sure that the temperature are controlled, very important. The neck and the upper airway are aligned, and that's what we call it sniffing position. And sniffing position, when you need to sniff something like this. So the tip of the nose and the tip of the chin are on the same level, a neutral level. You do it like that. The tip of the nose and the tip of the chin are at the same level. That's what we call it neutral position. If you do that, then you will open the airways, and that's the best position. Sometimes, most of the time you don't, but sometimes you have to put a shoulder roll below the upper part of the shoulder. And remember not to do very hyperextended, because hyperextension also will block the upper airway. And there is pictures at the end of the protocol. This protocol, if you have a copy, you will see what we mean, like the proper position. When we say aligning, mean the pharynx, the posterior, the larynx, and the trachea are in one direction, in one line, to facilitate better air entry. And we've talked about the rolled blanket or towel below the upper part of the shoulder to open that. Suctioning, remember, suctioning important to clear the airway. Okay, there is no need to suction the stomach. Remember that. Whatever the reason, if it's a blood or mucus, or it's very junky, anything, do not suction. The reason is because it will stimulate the vagus. Second, it might cause injury. And the third, it will take time. And fourth, it's a nutrition. The baby needs to eat it, absorb it. You don't need to take it out, even if it's blood. Okay? But the suction is only for the upper airway, to clear the upper airway if it's there is obstruction of the airway. That's all the suction. So remember, no suction, no need. The ventilation is controlling temperature, controlling sugar, asking the baby to breathe, and providing PPV. Remember, these are the principles: temperature, sugar, oxygen, breathing. Once the baby are correctly positioned, the mouth and nose are suctioned by bulb syringe, again, bulb syringe, okay? And if somebody refusing the bulb syringe in the labor room, report to me, okay? I will talk with him or him. We know we use bulb syringe. And if we don't have, we can use the mechanical suctioning. And if we don't have, we can use the electrical. So you can use the mechanical, the ball syringe, or you can use the electrical, or are correct. So first suction the mouth, because if the baby sniffs, the secretion will block the upper airway. And then suction the nose. Okay. Suctioning of either esophagus or stomach should be avoided if not indicated, as to produce vagal response and result in apnea and bradycardia. Remember that. You can wipe the mouth and the nose from the secretion. Okay. So I'm going to stop in a few seconds. If there is meconium staining LICA, no more suctioning of the trachea is required. Treat the baby, start NRP, because the question or the answer of one of the question at the beginning of resuscitation will be no, the LICA is not clear. So you need to start the ventilation. So, and remember, the rest of the guidelines and protocol are the same applied for baby with meconium. You do positioning, stimulating, warming, and so on. And then you decide breathing or heart rate. And if the heart rate below 100 in 30 seconds, start PPV. And the PPV should be effective. If it's 1 minute, then you decide below 60, chest compression and effective ventilation. Above 100, stop and give weaning oxygen. Between 60 and 100, continue PPV. Same, no change. If the baby has a meconium stain LICA or a clear LICA. Pulse oximetry. The pulse oximetry should be always applied. And remember, cyanosis is very late sign because it's a 5 gram. So if you need 5 gram to have cyanosis, if the baby hemoglobin is 15, for example, that means you need about 33% loss of saturation for cyanosis to appear, which means the pulse oximetry or the saturation will be 67. So we don't need to wait until we see the cyanosis. So that's why the oxygen saturation should be connected to measure the oxyhemoglobin. And remember to look at the target. You don't need, the baby does not need to achieve more than 91% if he's premature or 94 if he's a term within a few minutes. So look at the target when always prepare the pulse oximetry when the resuscitation is anticipated. How we anticipate resuscitation? By looking at the risk factors that we talked about it in the beginning of the protocol. If you need to use PPV for few breaths, then pulse oximetry is needed. If you have cyanosis, then pulse oximetry is needed. If you give oxygen, no oxygen without pulse oximetry. So remember, these are the indication for pulse oximetry. The best is to, of course, to do it in the right upper extremity. But if not, then put it anywhere else, but consider this is postdactyl. Always remember when you look at the target. And these are the target saturation depending on the time, and we have it in the protocol. You can look at it, and I think we have it hanged on the wall in the resuscitation room. And these are the remaining of the target oxygen until the baby reaching 10 minutes. Okay, now the oxygen. I think I will stop here after the oxygen. Okay, and then next session I will start from positive pressure ventilation. For neonate, more than 35 weeks gestation is always you need to give a blended oxygen. Remember, blended oxygen and 21%. If you don't have blend, start with 21%. Okay, 21% oxygen. But it's the best to give blended, and you should be ready for that, blended. And if you give flow, then start with room air. If the baby less than 35, start with somewhere between 21 to 30%. No, the lower the gestation, you reach to the maximum 30%. And then according to the target saturation on pulse oximetry, you decide to increase or increase. Remember, if you need more than 40 for more than 15 minutes, there's something wrong. You need to escalate your respiratory support. Okay? And remember, this will be repeated everywhere. Okay? Blended oxygen. No oxygen, non-blended, unless it's emergency and should be for short time. Oxygen in incubator is not allowed. Oxygen directly from oxygen, not allowed, even if humidified. You need to blend the oxygen because oxygen are a toxic medication. It's a very toxic. You're giving poison to the patient. Okay, so only given when you save life. And I'm going to stop here and I will continue the fourth session from positive pressure ventilation. So if you have any question, I will happy to answer. Questions? No? No questions? Okay, well, see you next session. Will be tomorrow morning, and it will be about positive pressure ventilation. Thank you very much for attending. Everybody, have a good day.
Thank you, doctor.
Thank you. Bye-bye.